It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preetish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
We have a 61-year-old gentleman, African-American gentleman with a history of lymphoma requiring chemotherapy and total body irradiation before allogenic stem cell transplant, and has now been diagnosed with a stage 2 versus stage 3A mid-esophageal squamous cell carcinoma. So he originally presented with several months of dysphagia, weight loss, and intermittent chest pain with eating. His ECOG performance status is 0. He was diagnosed 20 years ago with non-Hodgkin's lymphoma, treated with chemotherapy, followed by total body irradiation, followed by allogenic stem cell transplant. Details are not known. He has a history of diabetes and hypertension. He's a former smoker, former history of alcohol abuse, and former history of illicit drug use, but all discontinued when he was originally diagnosed with his lymphoma. Family history significant for breast cancer and a maternal aunt with ovarian cancer. In January of this year, he underwent staging studies with a CT scan of the chest, abdomen, and pelvis, demonstrating an atypical 0.8 centimeter upper mediastinal lymph node. EGD and endoscopic ultrasound demonstrated an ulcerated mass in the middle third of the esophagus, 1.4 millimeters in diameter, and an abnormal lymph node in subcarinal mediastinum, 7 millimeters by 6 millimeters, not sampled due to the proximity of the tumor. Pathology came back, I presume that's 1.4 centimeters, but pathology came back as moderately differentiated squamous cell carcinoma. Dr. Siegel, do you mind discussing the PET scan that was obtained?
Sure. You can see here we have one image from a fused FDG PET non-intravenous contrast study, and there's a very bright focus centered on the mid-esophagus, which is likely the primary tumor. On this one particular image, I do not see any enlarged nodes.
Thank you. So we have this challenging case with someone with a history of non-Hodgkin's lymphoma, treated 20 years prior, stem cell transplant patient, also had received prior total body irradiation. So what is the best approach for this person that has stage 2A or stage 3A esophageal squamous cell carcinoma? Dr. Kubi, can you provide your recommendations?
Yeah, I mean, the complexity in this case, Dr. Ng, is the discussion about the prior whole body radiation. So, you know, for a stage 2A, for a stage 3 for sure, we'd want to give pre-op therapy, especially for a squamous cell primary. And this is going to require, ultimately, if it comes to resection, a 3-field esophagectomy, because it's a mid-esophageal squamous cell, and you're going to have to do the anastomosis in the left neck in order to be able to get an appropriate node dissection and an appropriate margin on the primary tumor. So, you know, ideally, we want to give pre-op therapy. So I would defer to Dr. Benson and Dr. Patel to comment on what our latitude is in this particular patient before considering surgery.
Yes, Dr. Patel, I really need your opinion regarding this, because it's quite interesting. When I looked up recent guidelines, everything says, of course, chemoradiation therapy because it's squamous cell carcinoma, but we have this very complex case. So how would you proceed for this patient, with this patient in mind?
Yeah, first I might we might raise the possibility of a second malignancy here, maybe even related to the prior radiation. It just so happens that we recently treated somebody really in this exact same situation just in the past few months at our institution. I'll tell you from the first thing, it's often that you're not going to get all the radiation details. And what that means is you may not know what dose was given initially. And there are really differences. As low as 2 gray may have been used total body, and maybe as high as 12 gray in some cases or higher. So, I think you as a radiation oncologist, you've just got to be careful and really defensive in deciding about radiation in this case. So to me, what that means is a standard approach, something similar to the cross regimen with standard 3D fields or techniques is something I would not do in this situation. So I think we'd want to use advanced radiation techniques really to minimize the exposure of the spinal cord as really the first priority. And in addition to that, this is a patient who's had total body irradiation, stem cell transplant as a former smoker, and so the risk of pneumonitis is also going to be much higher in this case. So we'd want to try to find a way to minimize exposure of the heart and lungs as well. And so intensity modulated radiation therapy, if that's available, you may consider that. At our institution, this case, a similar case was treated with proton therapy. So proton radiation is probably one of the best choices in a situation like this to be able to concentrate the radiation dose in the target, the esophagus. Typically, the beams come in from the back of the patient, and then the proton beam will stop without any exit of radiation dose, and therefore you can treat what you need to treat in the esophagus without exposure into the lung or the heart, and at the same time avoid the esophagus. So we were able to achieve a full standard dose on a patient in a very similar circumstance without overt serious toxicity, and certainly at that point I'd refer back for consideration of surgical resection.
But for a potential site that may not have access to a proton beam facility, what would our next best option be?
Yeah. So intensity modulated radiation, or in some cases a hybrid approach where you give part of the radiation with 3D fields and then part with IMRT, would be the other approach. I think there's always also a question about the radiation dose. In North America, we've often used 50.4 gray. But of course, the cross regimen, really, I think, showed that 41.4 gray may be enough. And so also for a squamous cell carcinoma, which you might expect a better response to chemoradiation, you would consider decreasing the dose to 41.4 gray and then using an advanced technique really to limit the exposure of the spinal cord and the other organs as much as you can. But it's really the spinal cord that's key. And I think IMRT and sometimes IMRT with a combination 3D field is going to lead you to be able to do that, usually without difficulty.
Thank you so much. And then Dr. Benson, for this patient that's had a history of total body irradiation and then underwent stem cell transplant, do you have any concerns about choices of chemotherapy as your radiation sensitizer in this setting?
Well, yeah, first, just on etiology, I certainly agree that this could be a radiation-induced cancer, which can be a challenge in and of itself. But this patient also has other factors associated with squamous cell esophageal cancer, with smoking and alcohol use. And even under the best of circumstances, combined therapy is tough. And we would worry, for example, what will the bone marrow tolerability be? So one option, which might be a little bit easier, is just giving a fluoropyrimidine oxaliplatin combination. There's several ways you can do that with radiation. I think a lot of people normally would consider paclitaxel and carboplatin, but there you do run the risk of perhaps greater myelosuppression. So in a patient who may have comorbidities. Certainly, he's already been through a lot of therapy, and with the cigarette smoking, alcohol use, this will be a significant challenge. And this type of patient would have to be monitored and supported very, very carefully. But in general, our goal, as you mentioned, is chemoradiation and for most people to take them to surgery.